A warm welcome to Health and Lifestyle, your weekly health show for Matters Health. My name is Marie Yambo, and we do value your feedback, so you can interact with us on our social media platforms at KBC Channel 1 on X. Now, around the world and in Kenya, one of the greatest threats to human health is quietly growing. It's a silent pandemic that could push modern medicine back a century. Now, antimicrobial resistance, or AMR, is now claiming lives every few seconds as bacteria, viruses, and fungi evolve to outsmart the very drugs designed to stop them. Infections that were once easily cured with a simple course of antibiotics are now becoming harder and even sometimes impossible to treat. Now, this week on Health and Lifestyle program, we explore the global battle against antimicrobial resistance, and we speak to researchers on the front lines, hear stories from affected communities, and uncover what every individual can do, including yourself, to help slow down the crisis. And here's a look at what's coming up in the program.
What we see in our country is a persistent growth in rates of resistance of these pathogens to commonly available drugs.
These silent global threats, how superbugs are evolving, and why antimicrobial resistance is now considered one of the biggest health threats of the 21st century.
Alikuwa tu yeye mwili mzima na hata ukimshika ngozi yake ifinya hivi unaona some kind of yellow elements zinaonekana kabisa. Ni kama mwili wake hauja tuliona tu kuna lapsation, kuna kitu kinakosekana kwa mtoto. Haiko kawaida.
Newborns on the front line, babies under 28 days old face the highest risk of deadly drug-resistant infections. And what can you do? Simple life-saving actions you can take to protect yourself and reduce the spread of antimicrobial resistance. All that in the Good Practice segment. A warm welcome once again. Now to our first segment, where we explore the growing threat of sepsis in newborns and how antimicrobial resistance is making these infections even more deadly. For Stela and Omar, a couple in Kilifi County, everything seemed fine when they brought their newborn home. But just 2 days later, things changed. The baby's skin started turning yellow, his cry sounded different, and he just didn't look okay. What they didn't know, their newborn fell critically ill with sepsis, a life-threatening blood infection. Let's take a listen. Stela Suma and her husband, Omar Dima, recently welcomed a new baby. I paid them a visit at their home in Dara, Kilifi County. For Stela, pregnancy was a journey of both hope and worry. Diagnosed with high blood pressure, she was classified as high-risk case. At just 8 months, she delivered her baby through a cesarean section.
Kulingana na vile vipimo wakachukua ultrasound na wakaona kilo za mtoto ndani, hata akitoka anaweza survive. So wakasema sasa tukubali tuingie theater mtoto atoke.
But joy quickly turned into fear. Omar recalls noticing something was wrong soon after birth.
Alikuwa tu yeye mwili mzima na hata ukimshika ngozi yake ifinya hivi unaona some kind of yellow elements zinaonekana kabisa. Ni kama mwili wake hauja tuliona tu kuna lapsation, kuna kitu kinakosekana kwa mtoto. Haiko kawaida. Pia macho yake yalikuwa yako yellow. Mtoto hata sauti alikuwa akijaribu kulia haitoki vizuri, kama kuna kitu kinazuia hapa.
At the hospital, the focus was on stabilizing Stela, and once her condition improved, the family was discharged, hopefully that the baby would also get better at home. Instead, things worsened. 2 days later, the newborn stopped crying altogether. For 24 hours, he refused to breastfeed.
In fact, it happened usiku. By usiku anambia leo unajua ni kama ameshinda hajanyonya mtoto. Ilikuwa kama around kama saa 2 saa 3. Nikamwambia acha tuombe anaweza nyonya. Lakini kufikia ile alfajiri mwendo kama saa 11 nikamuuliza tena mama, na mama anasema bado amekata tena hata hajapata choo. Nilimwambia angalia hata ninapata kutoka hata sasa hivi. Na ndipo hapo tulimkimbiza siku yake.
And after testing, the baby was found to have neonatal sepsis.
Tulishtuka mwanzo kujua sepsis ni nini. Lakini zaidi ni kwamba waliposema watabaki na mtoto na atakuwa wana confirm ama kumtest tena kama mtoto anaendeleaje, kwa sababu ziko na levels I think.
Neonatal sepsis is a blood infection in infants under 28 days old. It is commonly caused by bacteria such as Staphylococcus aureus, Streptococcus pyogenes, E. coli, and Pseudomonas aeruginosa.
Sepsis could be acquired from the mother around that time of delivery, and then also you can have infection being acquired soon after birth from the hospital environment. So babies who have sepsis present with non-specific signs and symptoms, and this includes temperature abnormalities and difficulty in breathing, or they could present with inability to breastfeed. And because the signs and symptoms they come with are also found in other babies who do not have sepsis or infection, then it becomes very challenging for a clinician to distinguish those babies who have true sepsis from those who do not have sepsis.
On top of that, the baby's bilirubin, a yellow substance made when red blood cells break down, were dangerously high, causing severe jaundice.
Sasa ndo walivyomwangalia macho yake yako yellow, na huku mgongoni pia akifanya hivi ngozi kama tu yellow inamwagika hivi, inamwagika. Wakanipeleka kwa hao watafiti wa KEMRI, wakamchukua hivyo vipimo. Sasa walikuwa wanatafuta bilirubin levels kwa damu, ndo walivyopata iko juu, wakasema definitely haya ni manjano kulingana na hivi vipimo. Alafu akawekwa kwa matibabu yale ya taa, akamulikwa waka after 6 hours huko midnight, ndio nilipojaribu kumpa nyonyo akaanza kuvuta.
During sepsis, the immune system overreacts, damaging body tissues and releasing cytokines that disrupt the processing of bilirubin. This leads to a dangerous buildup, resulting in jaundice, yellowing of a baby's skin and eyes. Neonatal sepsis is treated with antibiotics to fight the infection.
Waliponi discharge, walinipatia antibiotics. Nikuja nimpatie zilikuwa tembe 10 za kumpa nusu. Kwa hivyo nikampa nusu za asubuhi na jioni. Wakasema nikifika nyumbani asubuhi, ile miale ya jua ile ambayo haijaanza kuwa mikali sana, namtoa bila nguo, anakaa hapo kama kwa dakika 10, alafu jioni hivyo ile jua likitua, ile miale kama bado haijakuwa baridi, iko na joto kidogo, namtoa tena bila nguo, anakaa pale kama dakika 10. Na hiyo itamsaidia kuendeleza kumaliza vile viini kwa damu yake.
However, antimicrobial resistance is making neonatal sepsis harder to treat because common bacteria are no longer responding to first-line antibiotics. As a result, infections progress faster, increasing the risk of severe complications and death in newborns.
So, sepsis is an important condition for us to pay attention to because its burden in newborn babies is quite high. It's among the leading causes of hospitalization and death during early life, and particularly in low and middle income countries where the burden is high, as I've mentioned. And in addition to that, these countries in such settings such as ours do not have adequate capacity to detect sepsis in a timely manner.
For Stela and Omar, the fear was overwhelming.
Mimi nilikuwa na wasiwasi sana. Mbona sikujua mapema? Nimeona mifano ya watoto ambao wamepata shida na venye imewapeleka. Sasa nilikuwa na wasiwasi upande wangu, sasa itakuwaje kwa mtoto wangu?
Omar says acting quickly made all the difference.
Sababu sometimes unajua kama Kiafrika maybe unaweza pata mwingine atakwambia nataka maombi, mtoto afanyiwe, pengine wameangalia na jicho baya. Unajua kuna kuwaga na myths mingi. Maana sasa kulikuwa na hisia kwamba sijui sasa kuna watafuta kama ni majani fulani mtoto anapata choo na nini, nikamwambia hapana, huyu ni wa kumkimbiza hospitali. Ndio tukapata kwamba alikuwa hajakosea, kwa sababu mtoto alikuwa na shida kweli. Na kweli nimeona tofauti kwa sababu baada ya matibabu hali yake imerudi kawaida, mtoto amerudi kawaida, ameongeza uzito, mtoto hana shida tena.
Today their baby is on the path to recovery. They hope that their ordeal can be a lesson for other parents to trust their instincts, act first, and seek medical help at the first sign of danger. That was Stela and Omar's journey, a reminder of just how quickly a newborn's life can change in a matter of just hours and the growing need for creating awareness. Now let's take a break, after which when we come back, we take a look at why superbugs are fighting back. Thank you for staying with us and welcome back. Now to understand just how serious antimicrobial resistance has become, we turn to one of Kenya's leading experts. Professor Samuel Kariuki paints a clear picture of the country's growing AMR crisis.
The situation around antimicrobial resistance globally has been increasing in the last 50 years. And it's very, very important for listeners to be aware that antimicrobial resistance is a natural process. Germs, as we know them, or bacteria, develop antimicrobial resistance as a mechanism for survival in their natural environment. So whether they are exposed to antibiotics or not, they will still develop resistance. But what matters here is the fact that if we misuse antibiotics, we accelerate that process. If we don't use antibiotics the right way, we accelerate that process so that the bugs or pathogens become resistant faster than would have happened. In other words, we shorten the lifespan of the usefulness of an antibiotic. In our country, for instance, we have seen rapid increase in resistance, especially for what we call healthcare-associated infections. These are infections that usually originate from the hospital setting. This mainly for patients who are in admission or admitted patients. And we've seen the likes of pathogens like Acinetobacter, Klebsiella, E. coli, and Pseudomonas becoming more and more resistant within the last 10 years or so. Very, very rapid resistance. And we're talking about here certain healthcare-associated infections showing close to 60 to 70% resistance to some of the commonly used antimicrobials or antibiotics. That's a huge increase sometimes. And the situation even with other types of what we call community-acquired infections. These are infections that happen within the communities and probably spread within communities, not specifically within the hospital setting, also have increased. We see in our studies, for example, bacteria like Salmonella in the last couple of years, typhoid fever that's caused by Salmonella typhi, for example, cholera that is caused by Vibrio cholera bacteria, showing consistently increasing resistance to drugs of choice. These are treatments that are specific for those bacterial infections. And again, a rapid increase in the last 10 years or so. In general, what we see in our country is a persistent growth in rates of resistance of these pathogens to commonly available drugs. And that is not a good sign. It just tells us that we are not using our antimicrobials in the most prudent way. And in so doing, we are accelerating resistance. And these are, I would say, goods that are very, very crucial for life sustenance. They are otherwise people who get infections sometimes have nothing left to be used for their treatment. That becomes life-threatening.
Exactly, that Prof mentioning people who actually may need this most, you know. We have patients who probably are going in for surgeries, or people who have, you know, the immune system is suppressed for one reason or another. So just paint for us a picture of how dire this situation is. You might talk about antimicrobial resistance. For me, I'm like, you know what? I probably don't take antibiotics, I'm healthy and everything, but there's a group of people that without these antibiotics working, then their lives are threatened.
Absolutely, very, very important issue that you brought up, because if you look at a patient who goes to hospital and is diagnosed with a bacterium like Acinetobacter or Klebsiella species, and this is a patient probably with a bloodstream infection. Now, that infection is life-threatening unless it's treated promptly. So if you then do your lab test and you find this particular bacteria is resistant to all the commonly available drugs or antibiotics in that hospital setting, what you try to do is to look for the next available higher level antibiotic. Obviously, it will be more expensive and probably less readily available. Now, if that doesn't work, you actually have left that patient to his or her own device in terms of recovery. And if the patient particularly is immunosuppressed, which often happens when we have particular patients with bacteremias or bloodstream infections, as happens with those that have comorbidities, as happens to patients that also have comorbidities like cancer or HIV or some other immunosuppressive condition, then that patient is likely to die.
So let's talk about a very special group, and these are the neonates. You know, we came recently from Kilifi, and we were talking about the neosep study and what it's trying to resolve. And this is a very special group of people, or babies for that matter, because there is no, can I say, a set standard of treating them, if I may use that word, in the sense that for an adult, you can talk about this dose because of the weight, maybe the age, and all that. And I think the study is trying to come up with a standard way of treating, these babies. How big a problem is antimicrobial resistance in this group of babies?
That group of babies, the neonates, are very, very fragile because this is the period when the immune system is literally very, very young and growing, and probably, I would say, very naive and probably not able to protect those neonates against any major crisis like antimicrobial resistant pathogens that would attack them. So it's a very vulnerable group. But secondly, as you clearly mentioned, it's also a group where for severe infections, very little has been done in terms of standardizing treatments and ensuring that the treatments also reflect that age and also reflect the fact that they need to be modified so that they are not necessarily toxic to that age group. And one of the key objectives here is to ascertain that the set dosages or dosage for those particular antimicrobials are the right ones for that age group. But secondly, also effective for neonatal sepsis, which is again a very severe infection that is life-threatening and could easily kill this particular young age group, unless there is clearly a new antimicrobial, a new set of antimicrobials that are effective against sepsis. Okay. And we have seen in this country, you go to any neonatal unit, the death rate can be extremely high if there's an outbreak of antimicrobial resistant pathogen.
I want us to go back to now to the general population. And we've talked about antimicrobial resistance being the misuse of antibiotics, being one of the major reasons as to why we're having AMR. There are other reasons. But you could just enlighten us. how do we, as a people, misuse antibiotics?
There are many, many ways in which communities misuse antibiotics, and key among them, for example, in our own setting here, is when individuals who are feeling unwell, rather than see a doctor or a nurse or another health professional, decide to go and buy medicines over the counter, pharmacy or some other shops that may be selling the medicines. There are a lot of infections that appear very similar in their symptoms or signs, but they are caused by different pathogens. Some of the pathogens are not necessarily treatable using antibiotics. For example, viruses. If somebody has upper respiratory tract infection caused by a virus, taking antibiotics doesn't help. But what does is that you take those antibiotics and you expose any other pathogens in your system to those antibiotics, and then, of course, provoke them to become resistant. Because once bacteria are exposed to antibiotics, the next thing they do is that they mount a fight. And that fight is a response to the antibiotic, and then they become resistant over time. Secondly, another way is, of course, sometimes use of substandard treatments. And this is something that can happen within our country unless we have strong regulations that monitor all the different types of medicines that come into our country. The other way that is also important, and which also has caused a lot of problems, is when patients are given a full dose. You've gone to hospital, but after you're given a dose for 5 days, antibiotics, or even 7 days sometimes. And after that day, you feel better and you start moving up and down, and you wonder, why should I take the rest of the dose? Again, you are exposing the bacteria to lower than normal dosage that should kill all the pathogens, causing complete recovery. And therefore, of course, then you, of course, are going to encourage resistance to arise.
Of course, dealing with AMR is a collective responsibility. So before we wrap up, let's look at a few simple actions you can take to help prevent antimicrobial resistance, steps that start right at home. Do's and don'ts for preventing and slowing antimicrobial resistance, AMR. The do's: take antimicrobials exactly as prescribed. Follow your healthcare provider's instructions on dose, frequency, and duration, and complete the full course even if you feel better. Practice good hygiene. Wash hands regularly and prepare food safely. Seek medical advice before using antibiotics. Only use antibiotics when a trained professional confirms they are needed. The don'ts: don't take antibiotics for viral infections. Common colds, flu, most sore throats, bronchitis, and many ear infections are viral and don't need antibiotics. Don't share or reuse leftover antibiotics. Medications prescribed for one person or condition may be ineffective or harmful for another. Don't stop antibiotics early. Stopping early can leave behind resistant bacteria. Don't pressure healthcare providers for antibiotics. Let clinicians decide if antibiotics are appropriate. Don't use non-prescription antibiotics. Over-the-counter antibiotics in some regions contribute to misuse and resistance. Don't misuse antibiotics in animals. Avoid using antibiotics to promote growth in livestock. Use them only under veterinary guidance and only when truly needed. That brings us to the end of today's program. A big thank you to Stela and Omar for sharing the story and to Professor Kariuki for helping us understand the bigger picture around AMR. And of course, thank you for watching and being part of this important conversation. Remember, protecting antibiotics starts with all of us. Goodbye for now, and see you next time.